Hi. So I'm going to finish up and maybe change the focus a little bit in terms of looking at an intervention that has the potential to reduce violence against pregnant women and therefore decrease exposure of their infants and children. So just a little bit different from SEEK in that we really are focused on the women. And I'm going to be talking about our NIH-funded project, the DOVE project, and DOVE is an acronym for Domestic Violence Enhanced Home Visitation, and primarily home visiting. And just so you kind of understand a little about my background, I started out life as a labor and delivery nurse in the military, and it didn't take long for me to see that in fact, African American babies are born too soon, prematurely, and they too small, so small for gestational age, and we have a high infant mortality rate in our community, which I'm sure everyone is aware of. And further, that as much as I love the excitement of deliveries, and had even thought about being a midwife at one point, the fact of how healthy a baby is going to be and the pregnancy outcome is determined long before the baby and the mom show up for the labor and delivery experience. So most of my work has been in community and trying to understand why we have such a persistent high infant mortality rate. And again, you don't do that work long until you find out that there is a high association between domestic violence, depression, poverty, and all of those risk factors. And I have spent most of my life doing home visiting, so you can see eventually how it all comes together. So I put these terms up to give you an understanding of the challenge for studying abuse during pregnancy, because there are many different definitions and many different ways that people look at it. And so when you're looking at research, you have to be kind of clear what part of the pregnancy they're talking about. And for me, I call what I do perinatal abuse, and that is generally when the woman shows up in the clinic, she's anywhere between 8 to 10 to 20 weeks pregnant, and after the birth, and usually up to the first year of life. We know that the early postpartum period, the 6 to 8 week period after the baby is born, is also a high risk period. And I have published previously a paper on the current evidence of home visiting, and home visiting has been a very important part of public health nursing for as long as there's probably been public health nursing. And most of it focuses on parents, but mostly because we want to improve child outcomes. So, how to be a successful parent, how to reduce maltreatment and child abuse, pregnancy spacing, making sure people get into pregnancy. But because I'm a women's health person, I think that if we can gird mothers up, all of those other things generally will fall in place. So most of what I have done looks at how we can improve mothers' exposure to IPV and thus reduce it for children. We also have a window of opportunity because if we ever get the Affordable Health Care Act in place, there is money for home visiting and evidence-based interventions, and all home visiting protocols must now include some way to assess IPV. And so we have a window of opportunity, and I think also because home visitors are engaged with parents for a significant part of the pregnancy, they have an opportunity to build a rapport and to really focus on the IPV in the family. And further, we know from OLS, which is the gold standard, the nurse-family partnership home visiting, in a reanalysis of the work, where there are families where there is intimate partner violence, his intervention does not work as well for the children and outcomes. So there is a need to do this. So just so you think I didn't dream up the DOVE intervention in one fell swoop, it actually builds on the work of Mary Ann Dutton, who developed an empowerment intervention, which was further incorporated into the 10-minute brochure intervention on domestic violence and pregnancy, developed by Parker and McFarland and published in the March of Dimes module. So it can be a trifold brochure. I then further tested that intervention in a pregnancy program in DC when we were trying to address the infant mortality rate there, and we put it on computer screens and also delivered it in clinics. And then I thought, well, if we could do it in the clinic, maybe we could do it in home visiting. And really our goal is to take a 10-minute intervention that can be integrated into any public health or any home visit program that takes about 10 minutes, but it's systematic, it's standardized, and people come back to it more than one time. So these were the goals of our DOVE intervention. It built on 2 evidence-based approaches, and we put it together in a standardized protocol. This was our model that we thought through the DOVE intervention we would give mothers information about intimate partner violence and why we were concerned about it in pregnancy, to also provide her information about parenting and how to continue to be safe in the face of violence in the home, and also to help and to introduce her to community resources and to help her with decision making and problem solving, building her skills. It was not an intervention that told women that they had to leave, but how could we keep them safe and their children. These were the outcomes in the middle that we were looking at, so maternal outcomes in terms of decreased frequency and severity, increased use of safety behaviors, increased use of community resources, and I don't need to read that, but we had a mental health component and physical health. And for the children, we indirect outcome would that they would have a decreased exposure to violence, and their physical health would be improved, and growth and development. And we also looked at some psychosocial development in terms of language development for the children. This was a very complex model, but basically it's a randomized control trial. We had 3 different settings. We tested our intervention in the urban setting, which was Baltimore, and women were individually randomized to either receive DOVE or usual care. In Missouri, we had 12 health departments, so the health department randomization occurred at the health department level, and then we did a small subsample of the Olds family partnership program, of which we did 20 cases, and we will match those with controls out of the database. And we followed the women through. We picked the women up at about late pregnancy, 3rd trimester, and followed them through for 24 months after delivery. This was a very complex. The way that we were able to access the mothers in Baltimore City was pretty complex, and it had many levels of referrals, and it is likely accounts for why we have such a small sample here. But the bottom big chart just kind of tells you that they had to have experienced IPV within the last year. They had to be less than 31 weeks gestation, and they had to be over age 18. And then we did 3 of the brochure-based interventions that was integrated into the standard home visiting protocol. They had 3 sessions prenatally and 3 sessions postpartum, and again, a description of the data collection. So again, just another of the outcomes that we were interested in looking at for the families. And so we have now completed data collection. We are relooking at and rebuilding our analytical models, because one of the things that we probably were not expecting is that women had on average at least 3 abusers during the course of the pregnancy. Sometimes it was the father of the baby, sometimes it was a new relationship, and so we're having to build models that allows us to tease out what that's going to look like. So a little bit more complex than we thought. But in the first cut of data, just these are preliminary data of the first 200 women in the data set, and you can see baseline is the column furthest to the left, and overall sample, so fairly young sample, and then the DOVE sample is in the middle, and the control sample is the farthest right column. So not a lot of difference between the 2 groups. Setting-wise, Baltimore has more African Americans, and our Missouri sample has more European whites, but they are both Medicaid samples and both very low income, poor women. So again, here is just a few selected measures. You can see that high levels of abuse, both on the conflict tactics and the severity, the SFAS. High levels of depression, generally around 10, we would be making a referral. This is the Edinburgh, and fairly low self-esteem, and that's usually the way the relationship works. So, are we making a difference? If you look at on the Dove sample where the conflict tactics score started out, so at delivery was down to 22.7, and at 18 months, 13.5. So trending in a good way. The same relationship we can see across time points. We were most impressed at even 18 months after the intervention. So now at 18 months, they are at least a year post-intervention, they are still reporting lower levels of violence. And then the mental health, I think, is going to take a little more thinking about. High levels in both groups at baseline, remarkable decrease at 18 months, but some of that is also just related to being not pregnant for most women. But still the intervention, the control group has a higher level of depressive symptoms and a lower level of self-esteem. So when we get the whole sample in, we'll continue to look at that trend, but we are guardedly optimistic. The other thing that we've also found anecdotally is women really talk about the value of the intervention in terms of allowing them to start where they are. And so sometimes there are other emergencies and situations that need to be taken care of, and so public health nurses generally know how to do that, and then we are able to come back to the intervention or postpone it to the next visit so that they still get free. Typical, I think, for these kind of intervention studies, we've had women that are pregnant again and would like to be in Dove again, and we absolutely say, we are very flattered, but we don't think so. So what has been very helpful, women say, is actually being able to think out loud and talk out loud with a home visitor that will support their thinking through the decision making. The other thing that we have some other interesting data on are this is a sample of all abused women. The proportion of women having small for gestational age babies, and I see one of our Dove team members is sitting there, Ify, is much higher than the CDC and national averages. So we looked at both small for gestational age and low birth weight babies. And in Baltimore, the rate nationally for non-Hispanic blacks is about 17%, and we're at 22% here in Baltimore. And in the rural area, which is a proxy for a largely white sample, their rate is almost twice the national average of small for gestational age. The other thing that's very interesting is that we also have a much higher level of cigarette smoking in our rural population than we do in our urban population. So we have a lot of things to actually look at and think about as we try to interpret the results. We did find further that when we looked at the risk factors for the two sites, rural and urban, that there were no associations between small for gestational age babies and IPV in the rural sample, but in Baltimore, sexual coercion. So most of these women were reporting both emotional abuse, physical abuse, and sexual abuse. Was much more predictive of having a small gestational age. And protective was younger age, and being employed reduced the risk of having small for gestational age. So the age age situation provides some preliminary support for some of the thinking around the weathering of African American women. And we know that generally it's not the first baby that African American women have that are small for gestational age or low birth weight, but it's usually the short interval and frequent babies, and this sample would suggest that. So what have we learned? And that partnerships are very important. We develop partnerships not only here in Baltimore, but also with 12 different health departments in Missouri. And the missions are different, but what's the kernel that's the same between both is that their emphasis on improving maternal and child health. So we were able to do the kind of academic community partnership. We actually train nurses in all of the health departments to be able to do the intervention, and so that in some ways the health departments own the intervention in a different way than when you send a research team in to do an intervention. We did publish a paper on this notion of developing the town, which is home visitors and gown, which is us, the academic partners, and what it takes to do this. And we very much had the full support of both health departments for us to be in there. And in fact, in Missouri, the health department has developed the DOVE protocol as their evidence-based intervention for home visiting, for IPV. We did a lot of things to try to make this feel natural to home visitors, frequent meetings, newsletters on topics they wanted related to IPV, many professional trainings, and just kind of a presence to make the partnership work. There are, of course, many challenges in trying to do these academic community partnerships. First, just for the home visitors to even understand the nature of the research, on unevenness in the training, both their professional preparation as well as their understanding for IPV, their whole discomfort around screening. And so based upon that, we continued to look, and our accrual rates were very small, so we actually did another smaller study of the home visitors themselves. And not surprisingly, many of the home visitors, the majority of them, had either a lifetime IPV exposure or current situation, most of which these nurses had not received any kind of help or support for. So screening became a real challenge for a lot of the family, the women, the nurses that were doing this. And it usually was after about the 6th or 7th training that myself and my co-PI, Linda Bullock, did, that all of a sudden the home visitor gets it, and they get that if I don't screen, I'm further re-victimizing the woman because I'm taking away her right to make a decision and to problem solving. So I think that's probably one of the biggest challenges of doing this work is really getting home visitors to be able to feel comfortable in screening. Some of the challenges of doing these kind of partnerships is the control over what, and so for us there was a lot of control over just getting access to patients. Communication, making sure that everybody was always aware of changes in staff and policies and procedures, and then the continued motivation. Of course, we as researchers are highly motivated to continue, but also bringing our health department colleagues along. So we found that DOVE does combine 2 evidence-based protocols, that it could be integrated into existing culturally appropriate protocols. It's fairly low cost to implement, and it does require training and for home visitors, and it has to be really interactive, lots of role playing and those kind of things. And the women like the intervention. We did a final, at 24 months, final question on what women thought about the intervention. I think to take this up to scale is I would love to see be able to do this with federally mandated home visit programs like Healthy Start or Early Head Start, where we have an opportunity. All of those programs have required home visits, and where we could have nurses and social workers who do home visiting to implement a systematic protocol like that. Thank you. I don't know if there's.
Did you say that in the proxy? Did you say that in the proxy, the rural county, that the low birth rate was twice as much as the city? Did I understand?
No. Twice as much as the national average for whites.
So even the rural was. Mm-hmm. That just seems strange.
We're still analyzing, but they do. Where it becomes very challenging is there was a higher rate of cigarette smoking also in our rural population, and we know that cigarette contributes to that. So I think the combination of it is often not unusual to find abused women increase their use of substances, and I think a lot of times people don't think about cigarettes, but that is also a substance that women use to manage their stress and with IPV, along with poverty. You know, there's lots of rural poverty too. Thank you.